The clenched fist as a result of spasticity is a challenging problem for hand surgeons. My name is Vaikuntan Rajaratnam, and I'm going to take you through the various aspects of spasticity in the upper limb, and specifically pertaining to the clenched fist, its assessment, how I analyze the problem, and how I choose the patient, select them for surgical intervention. I hope it is helpful. I'm open for debate and discussions. Feel free to contact me. My philosophy when approaching problems of spasticity is to understand the cognitive load that spasticity produces on the patient. You have to examine the patient as a whole, have an understanding of your patients, and this is an important concept before you embark on surgical intervention. Because of the nature of spasticity and the impact on cognitive load, we must understand the concept of the ideomotor axis. And this is something that you need to understand to see how a peripheral surgery, from a neurectomy to a correction of deformity, can have significant impacts centrally, but also in the lower limb. So there is, when we make a motor action, there is a cognition that we decide we want to do an action. And the action is then carried out through the neuromuscular system and the muscles to achieve the goal of our movement. And from that goal, when we're able to grasp an object, we have a reward. That is the reward of able to have the sensory feedback, the haptic feedback of having achieved that goal. And that provides the motivation to continue with motor action. And this is an important concept to understand, especially when it comes to rehabilitation.
To understand the human grasp, which is an important aspect in upper limb surgery, we need to understand that there are neurons that would fire from the command center in the brain, and this has been shown through some studies. A single neuron for a complex task like a grasping action, a single neuron has been trained through a process of neural coding to fire multiple circuits to produce the complex motor function to produce the activity of grasp surgery. It is also very important to see how new neural pathways are created following an injury. And there are very interesting studies that have been done to show the mapping that occurs. There's not only a mapping that occurs in the brain that we are familiar with, the homunculus, similar mappings are available in the spinal cord. So there are command centers in the spinal cord that would single neuron would fire as a result of predetermined complex commands from the brain to ensure that rapid motor firing will occur in the peripheral organ in the limb.
Based on the framework that I've just explained, this is how I would assess my patient for a clenched fist. So to be able to fully understand, we need to understand the causes of that deformity. There's a physiological cause, which is the hyperexcitability, and we need to see which of those muscles in particular is affected in the hand to produce that deformity. Then the pathological causes for the um, deformity needs to be evaluated to understand the neuroplastic changes that occurs. And here we also will look at the length and the amount of intervention that has occurred early, whether there has been disuse atrophy, is there contracture, and the functional evaluation of the patient. And a thorough understanding of the patient's expectation is crucial here, because otherwise your type of surgery and your outcomes are going to be very poor. And then finally, to make that decision on what kind of surgery and where we're going to do is the anatomical evaluation of the impact of spasticity in the hand. So which are the muscles from the FDS, FTP, FPL, FCU, FCR, and the intrinsic muscles. So we go through that very systematically, and I won't go into the details, which I'm sure you would have already had this in the earlier part of this conference. Yeah, I'd like to just kind of put into a table on how we use the various intervention once we have selected a candidate for surgery or in the process of selecting. So the role of Botox injection in my practice is mainly in early and moderate spasticity, One is to obtain temporary relief, but I use it more of a diagnostic tool. When they appear to me and it's been referred whether we could do surgery, we'll give them a diagnostic tool where we inject the muscles that we think that are affected with accurate palpation. And once that is done, we wait for the patient to come back and tell us how do they feel, whether it was any good, any better. We must make sure that the patient has had some effect, and we'll tell them that this doesn't last within 2 to 3 months, the spasticity would return. And from there, we then move on to neurectomy. So once I've made a diagnosis, the patient feels that there is a benefit from the intervention, then we go ahead and do the neurectomy. Then we have various other things like tendon lengthening or tendon transfer. So this is dependent upon the amount of chronic contracture that has occurred, and then we consider whether it's going to divide the tendon, we're going to lengthen it, or we're going to then balance it with the use of a tendon transfer. We'll see some with the cases. The other state is when there's low function with severe deformities, as in the clenched fist that we will discuss. Then we think about the address the chronic deformity from fixed contractures, both of muscular tendinous unit and also of the joint. And then we will consider how we could improve from function and cosmesis. Here's the algorithm for surgical intervention. So the initial assessment is done, then we decide whether there's a non-surgical intervention role here, and we use a multidisciplinary team, and I listen to my therapists who spend time with the patient, they understand the patients, and they have the final say in my practice whether we proceed or we don't proceed, apart from the physical assessment. And then we determine the surgical need. How can surgery help this patient? And in process, we make sure we have a relationship with the patient with the 2 or 3 visits before we then plan the surgery with them. We manage the expectations. That is crucial component. And then we explain to them the post-operative rehabilitation that is required. And in this sort of situation, the use of splinting devices till tissue stabilization occurs. And here is a slide that shows the causes of clenched fist spasticity and which of the, based on an anatomical basis, as I explained earlier, and what are the various surgical strategies. So for tendons that are tight, we work either in tenotomy or Z lengthening, or do tendon transfers to rebalance. For the muscles of the hand, we would consider lumbrical or interossei release. And for the tena muscles, we do either neurectomy, there's no contracture, otherwise we release. Sometimes you have adduction contracture, partly due to positioning. Then you have to do adductor release. And then we do combination of tenotomies and lengthening. And sometimes in the hand, rerouting of tendons is quite useful, especially for the clenched fist. Sometimes you reroute tendon from the flexor tendon to the extensor to balance it, especially with deformity correction with excision arthroplasties of the metacarpophalangeal joint, which we'll go through later. And here's the list. I won't go through this and how we go about working on each one of those tendons and how we the indications for them. You can read this. We did a literature review to find the evidence for the various treatment for spasticity, and this is our spasticity care pathway and our algorithms for the patients to be referred to the team, and how we use surgery, which is about 1 in 5 patients referred to us undergo surgery. Spasticity presents itself with, apart from the loss of function, is the pain that is produced by the spasticity within the muscles, the easy fatigability, and the presence of involuntary movement. They then, if neglected, ends up in severe contractures of the musculotendinous unit with skin maceration. And also it's very important to understand there is a problem of self-image with spasticity and the stigma of the deformity. Our referral criteria for spasticity need not be confined to stroke. We also accept those with spinal cord injuries and also neurodegenerative disorders. And we've seen a few cases of post-psychotic medication dystonia that we use for the treatment of our spastic presentations. With our inclusion criteria for our patients, we only consider surgical intervention in those who are functionally good and who are able to perform in society.
Bed-bound patients are not included into our patient selection for surgery unless for hygiene and nursing purposes. These are the two instruments that we use to measure the hand function from spasticity using the House classification. And for the extent of spasticity, we use the modified Ashworth scale. These are validated instruments, however, they do not totally measure the impact of the spasticity on the psychosocial and the biological aspects of the patient comprehensively. These are our treatment modality. We only treat patients who are got a good expectation of improvement, and we also use to relieve contractures. These are our non-surgical methods, which are splinting, the use of oral medication, physical therapy. We use Botox mainly for the purposes of assessment as a therapeutic trial to see whether the patients feel better with the relaxation of the muscle prior to doing neurectomies. Surgical treatment, apart from deformity correction with tendon and muscle procedure, we also do arthrodesis for stabilization, and most importantly, in early cases and in selected cases, we perform selective neurectomy. Occasionally, we have conducted amputations.
There's been evidence shown in the literature that surgery in the upper limb helps improve the lower limb. So this is an important concept to understand. I first described this about 6-7 years ago when we did the neurectomy in the upper limb for a patient, and his main one of his positive outcome was an improvement in the overall gait in the lower limb, and has been shown as a result of the reduction in the cognitive load and also as a reduction of reduced excitability in the corticospinal tracts. You must realize the motor neuron in the upper limb are very close to the motor neurons of the lower limb in the Forrester's lamination of fibers in the corticospinal tract. And therefore, by reducing the hyperexcitability by neurectomies, you can improve the lower limb function because the adjacent lower limb neurons are not hyperexcited, hyperstimulated as a result of the upper limb surgery. So this is an important concept to think about as you progress with your treatment plan, and this is something you need to counsel the patient about.
And the other important thing is there are significant benefits from upper limb spasticity correction surgery, especially in very severely disabled spasticity, from improving body function, in gains in activity in social life. So it not only improves the biophysical aspect, but also the psychosocial aspects. This is a qualitative study that was done from Sweden, and I think it's very important that if you want to measure the outcomes in spasticity, that you should do qualitative studies, because if you try and measure the improvements in the functional gain, you may find it very little, but the cognitive load is significantly reduced because of the reduction in the spasticity, and this requires further work.
So this is the step-by-step guide on how we correct our cases. Our cases are mainly very established contractures with fixed deformities in the metacarpophalangeal joints, and even we see a case where there's secondary pressure ulcers as a result of the deformity from skin exposure to metacarpal head excision, arthroplasty with soft tissue balancing, reconstruction, and closure. Here's a patient who's in the 60s with a non-functioning upper limb from severe spasticity, both affecting the elbow joint and also the wrist and hands with a clenched fist. As you can see here, there is a significant amount of contractures with inability to extend the wrist nor the fingers, and this was a patient who was under general anesthesia. So we make an evaluation, and the final surgical plan is only determined after a full examination under general anesthesia. And so now we can see that this patient needs a little bit more than just pure metacarpophalangeal joint deformity correction. And you can see on the right side that the various tight tendons, the FCR, the FCU, were all very tight, and the metacarpophalangeal joint are fixed and in flexion, and therefore, following this, a re-evaluation of the surgical plan was done, and you should see later what was the surgery that was done. Here's another view of the patient. As you can see, there pressure ulceration in the thumb as a result of severe hyperextension deformity, and you can see that there are pressure changes in the interdigital spaces of the ring middle and little finger with ulcerations, and therefore the importance of ensuring that these are corrected during the time. So in this case, these are the various procedures that was done. Proximally, a biceps and brachialis tenotomy was done to address the flexion contracture at the elbow. This would help with nursing care. As for the first web space contracture, an adductor tenotomy was performed, and this allowed for the opening up of the grasp action so as to again facilitate nursing and hygiene. And then for the wrist severe flexion contracture, a tenotomy of the FCR, palmaris longus, and FCU was performed. However, the correction was still restricted. There was still a significant flexion deformity for which proximal row carpectomy was performed, and this was then augmented with a metacarpophalangeal joint excision arthroplasty. However, there was still significant flexion deformities in the IPJ, and thus FDS tenotomy was also conducted through the metacarpophalangeal joint incision as shown, and this tenotomy allowed for the fingers to extend as can be seen. As for the IPJ joint, as the pressure necrosis that was seen in the IPJ of the thumb had caused an exposure of the head of the proximal phalanx, and this was then excised. These were all the surgery that was done for this patient. And here's the results 2 weeks post-surgery. As you can see, the wounds have healed from our transverse incision that we use with continuous horizontal mattress sutures for closure, which is a quick closure. You must remember that these patients are high-risk anesthetics patients, and so therefore the surgery must be quick to reduce the risk to the patient's life. And these are all usually done under general anesthesia because they don't cooperate with block, but usually augment with the block for post-op pain relief. And here you can see how the tongue pressure ulcer has healed over 2 weeks following the surgery because we have removed the pressure with our surgery to correct it. This is another patient. As you can see, there was significant amount of contractures in the metacarpophalangeal joint and also the interphalangeal joint. And you can see that post-excision arthroplasty that the joint is now much supple, and the patient can open the hand and makes a significant difference in the deformity. Following stabilization procedure, the joint will become more stable and the skin will be closed. This is another patient, and in this case you can see that the palm was not visible preoperatively, and post-surgically we can now see how the the deformity has been corrected and the palm is opened up. As you can see, it's just beyond surgery. We need to be able to assess our patient from this lecture. I hope you understand the philosophy behind the careful assessment and careful understanding of the patient's expectations and need. And in the examples I've shown, sometimes the surgeries, there's no one surgery that fits all. You have to be able to think critically on the table, especially under general anesthesia, and alter your management as and when as required by the patient. So it's a combination of tendon transfers, excision arthroplasty, soft tissue balancing, and to get the patient into a better functional position. Whether there is functionality or there's no functionality, treatment again will vary. So this is for the clenched fist, and I hope you have a understanding, and I'm happy to take questions. Thank you and good luck.